All right, class, let's talk about pain. Pain isn't just an uncomfortable feeling, it's one of the body's smartest survival tactics. It keeps us safe in the moment and teaches us what to stay away from next time. Think of it as the body's alarm system, always ready to warn us when something's wrong. And that's where we come in. Nurses live right in the middle of that space between pain and healing. We're the ones who see it first, assess it, give the medications, and teach patients how to manage it. We spend more time with patients than anyone else on the healthcare team. That's why nurses are considered the primary managers of pain. Now, how do we define pain? The American Pain Society says it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. In simpler terms, it's both physical and emotional. Pain isn't just in the body, it's in the mind too. And there's a definition I want you to memorize. It comes from McCaffery. Pain is whatever the patient says it is, existing whenever the patient says it does. That means if your patient tells you they're in pain, you believe them. Their self-report is the gold standard. We don't question it, we assess it. Pain affects everyone, every age, gender, and background. It's one of the main reasons people come to us for care, and when it's not relieved, it can cause chaos. Unrelieved pain doesn't just hurt, it changes how the body works. Hormones shift, blood pressure goes up, breathing slows down, immunity drops, and mood and sleep take a hit. Over time, it can even lead to depression or hopelessness. Let's make this clear. Pain isn't harmless. It's a stress response that can hurt every organ system if we ignore it. For example, when pain isn't controlled, the endocrine system floods the body with stress hormones like cortisol and epinephrine. That raises blood sugar and changes metabolism. The heart starts working harder, blood pressure climbs, and oxygen demand increases. Breathing gets shallow, which means less oxygen and a higher risk for infection. The gut slows down, urine output drops, and muscles tighten. Patients become exhausted, anxious, and sometimes confused. And when this keeps happening day after day, the immune system weakens and patients start losing hope. They can't sleep, they feel trapped in their own body. So when I say pain management is critical, I mean it literally saves lives. Now let's talk about how we classify pain. Pain can be acute or chronic. Acute pain is the kind you expect after surgery, trauma, or a procedure. It usually improves as the body heals. Chronic pain sticks around for months or years. It can come from arthritis, diabetes, cancer, or nerve injury. Sometimes it flares up suddenly. That's what we call breakthrough pain. Pain can also be described by its cause. Nociceptive pain is the body's normal response to injury or inflammation. Neuropathic pain comes from nerve damage or abnormal nerve processing. And some conditions, like cancer or sickle cell disease, that include both types. Let's break down nociceptive pain a little further. There are 4 key steps in how the body senses and reacts to pain: transduction, transmission, perception, and modulation. Transduction is where it all begins. Something harmful, a burn, an incision, inflammation, triggers pain receptors called nociceptors. The body releases chemicals like serotonin, bradykinin, histamine, and prostaglandins. Those chemicals start the pain signal. This is where NSAIDs come in. They block the enzyme cyclooxygenase, or COX, which prevents prostaglandins from forming. That's how drugs like ibuprofen or naproxen reduce inflammation and pain. COX-2 inhibitors like celecoxib target inflammation more specifically. Acetaminophen works mainly in the brain. It helps with pain and fever, but it doesn't reduce inflammation. Local anesthetics block sodium channels, stopping the pain signal from firing. Some anticonvulsants block calcium channels and limit excitatory neurotransmitters. So all of these drugs target that very first step in the pain pathway. Next comes transmission. The pain signal travels along nerve fibers to the spinal cord and then to the brain. Fast A delta fibers carry sharp, quick pain. Slower C fibers carry dull, burning pain. As that signal moves through the spinal cord, neurotransmitters like glutamate and substance P amplify it. They make the message louder. Then comes perception. That's when the brain finally says, okay, this hurts. The brain gives meaning to the pain. It's where the emotional part shows up. Fear, anxiety, anger, or sadness. This is also where things like distraction or guided imagery can help. We can't always stop the signal, but we can change how the brain reacts to it. Finally, we have modulation. That's the body's built-in pain control system. The brain releases serotonin, norepinephrine, and endorphins to calm things down. Some antidepressants work here by keeping those chemicals around longer, which helps reduce chronic pain. Now, not all pain follows that normal pattern. Neuropathic pain is different. It happens when there's damage or disease in the nervous system, either in the peripheral nerves or in the brain and spinal cord. Think about diabetic neuropathy, shingles, or nerve compression. Patients describe it as burning, shooting, stabbing, or electric. Neuropathic pain doesn't always respond well to regular pain meds because the issue isn't inflammation, it's nerve dysfunction. Researchers believe it happens because of changes in ion channels, overactive nerve signaling, and sometimes even problems in how cells clean themselves out. What's called autophagy. That's why drugs like anticonvulsants or certain antidepressants are used. They help stabilize those channels and rebalance neurotransmitters. Neuropathic pain can start anywhere along the pain pathway. When nerves in the periphery become damaged, they can misfire or reorganize in strange ways. That's called maladaptive neuroplasticity. This makes them overly sensitive, a process known as peripheral sensitization. That's when patients develop allodynia, pain from something that shouldn't hurt, like clothing or bed sheets, or hyperalgesia, where something mildly painful feels much worse than it should. But central mechanisms can make things even worse. In central sensitization, neurons in the spinal cord or brain become overly excitable after repeated stimulation. Neurotransmitters like glutamate activate NMDA receptors, flooding the cells with calcium, and the pain keeps firing even after the injury heals. Over time, the spinal cord can actually reorganize itself. Nerve fibers start sending pain signals from areas that shouldn't even hurt. That's why untreated pain can become chronic. The nervous system literally learns to stay in pain mode. So here's what I want you to remember. Pain is personal, complex, and powerful. Always believe your patient's report. Untreated pain changes the entire body. Know how and where your medications work. Use both medication and non-drug strategies, things like relaxation, distraction, and guided imagery. And most importantly, advocate early, assess often, and treat effectively. Because pain management isn't just about comfort, it's about safety, healing, and dignity.